So you have to click your got it. Let's see, to start, we really want to know who's here. We don't have time for introductions. So if you will use the chat to tell us your name, your organization, and what it is that you do in this space. We're really interested in knowing who our audience is and how we can better tailor our offerings for you. So we've had 2 back-to-back sessions today, and this one will go on time and will end on time. A brief background about the consortium for those of you who are new or didn't just hear me tell this an hour ago. So the consortium itself is actually new, and we're a statewide entity aimed at advancing the integration of non-medical solutions into the healthcare delivery system so that we can improve health outcomes and reduce health disparities across the state. We think the consortium is both needed and timely. There's growing momentum across the state around the integration of NMDOH into the healthcare delivery system. The state has an action plan. There's been legislation this session, and we're increasingly seeing health plans, providers, clinics, all sorts of healthcare organizations invest in the non-medical interventions on behalf of their patients. They understand that these are really effective means for improving the health of their patients outside of the medical care that they also deliver. The consortium is intended to be that dedicated space for all stakeholders to come together to share, to learn, and support what's working as we build this field of NMDOH practice in Texas. One program highlight that I want to tell you about, last month through our website, which is driversofhealthtx.org, we launched a program index. And the purpose of the program index is to catalog all of the NMDOH programs across the state that are sponsored by health system organizations. Until now, there hasn't been a place you could go to and figure out who's doing what, whether it's been evaluated, which populations they're serving, et cetera, et cetera. And so the purpose of the index is to create a single repository that'll feature abstracts of programs. It has searchable fields like program sponsorship, particular drivers of health you may be interested in, target populations, particular health conditions, counties where the work is being sponsored, and also, of course, evaluation status. Our goal is for this index to serve as a resource for everybody who's working in this space so that we know who's up to what, so that we can learn from each other, and so that we can share knowledge as we grow this field. But the program index will only be as robust as we all make it. And so I'd like to invite you to take a look at the index. And then if your organization is doing this kind of work, we want to include it in the index. Entering programs is really easy. Jackie Klotz from our staff can walk you through it in real time. I think she's put the link to the program index in the chat along with her email. And so please hang on to this information and give us a little bit of your time, and we will get your stuff entered in there, and it'll help you show off what you're doing, because I'm sure it's impressive, and it'll help your colleagues because they'll have more opportunities to learn from you. So now let's get on to our session for today. Our program today is called Evaluation and Systems Thinking, a deep dive highlighting the steps towards systemness. Leslie will have to explain what that means. We're going to have time at the end for Q&A, but feel free as we go along to put comments or questions into the chat throughout the presentation. We've got people monitoring the chat, so we shouldn't lose anything that you put in there. And at the end of the webinar, we'll again put the link to the program index back into the chat, because we really do want your programs. So now I'm excited to introduce Dr. Leslie Wainwright, who's going to lead our discussion today. Leslie is the Chief Funding and Innovation Officer at Parkland Center for Clinical Innovations. Her experience has ranged from academic research, pharma, biotech, as well as healthcare delivery. And she's going to be sharing some of her expertise around evaluation with us today. So without further ado, Leslie, take it away, please.
All right, Alina, thank you so much for both your introductory comments on the consortium as a whole, as well as introducing me as the facilitator for the panel. What we're going to do in the time that we have is I'm going to do probably about a 5 to 7 minute preamble narrative, partly to connect what we're going to discuss with our panelists today with some of the key discussion points from the first session that we did in June. I'm going to tee up a couple things to listen for once we get into the panel discussion. And then we're really going to dig into some very thought-provoking topics during our discussion. So as a reminder, when we got together earlier this year, both Steve Miff, who is our president and CEO of PCCI, and myself, we've been working with Elena and Jackie on the consortium team, specifically around an affinity group that's focused on impact evaluation and measurement. And as part of that, we put some grounding principles together that we use to when we get together as a small steering or affinity group, but certainly when we bring our thoughts and perspectives to the broader community. And so to reinforce these, I felt it was important just to reiterate them again. One, this idea that we don't have all the answers. So as we look towards the program index, as Elena mentioned, as we want to bring all of you in the discussion around impact measurement and narrative and evaluation, we can only advocate for the change that we want if we recognize all those nuances that really come into effective measurement approaches and strategies. Secondly, measurement, at least in our opinion, it should be the first, not the last thing that one thinks of, because how you design what you measure is part and parcel with what you want to achieve. And so making sure that we're entering into this measurement discussion very early on is very intentional for us because of the second guiding principle. The third being that we know that impact measurement can be overwhelming. In fact, when I was doing a prep call with one of our panelists, we talked about this idea like big S systems and small S systems, and this idea that you again can't let that perfect get in the way of the good. And if you think about kind of Pollyanna and that zone of perfection, it almost puts you in a state of paralysis. And so the grounding principle for us as well was this idea that while impact measurement can become overwhelming, it is achievable with the right kind of guardrails, tools, data, and collaborators. And the fourth one, which is probably the most geeky or dorky, is this idea that measurement is for everyone. And we certainly believe that because data stories, stories that inspire the brain and the heart are the way that change happens. And unless you have good measurement design, those stories will not be as powerful as they can be, which means change won't be as impactful as it could be. So every time we do a session, we'll bring these grounding principles back just as a way to anchor what we're all about in this big wide world. The reason for this particular topic as our 201 session is we did some internal polling during the session that we did in June. And we asked the participants to rank order of the 5 challenges that we spoke about, which were the ones that would be most challenging. And the one that rose to the top was this challenge around we live in silos, but we need to measure impact as systems. So that was our mandate to dig into this a little bit more deeply and why we brought that to this group as our first more advanced or first 201 session. 2 or 3 recap slides from the session that we did in June. One, that system thinking is really this idea that it is a skill set, that it blends a lot of things that we know. It blends a little bit of strategy, blends a little bit of operations success, it blends a little bit of innovation. But at the end, it's the parable of the elephant, that you can tell the story based on the part of the elephant that you touch, or you can look at the elephant in its entirety. So when we think about non-medical drivers of health, there is so much intersectionality between families who have multiple needs, between the providers who provide multiple services, between that unusual dynamic and intersection between clinical and community care. So all of those places of intersection make clinic to community and or the way we think about non-medical drivers of health is something that really lends itself to an approach that has more of a systems orientation. And then finally, at our last session, we talked a little bit about what are those types of dimensions or characteristics that if we were going to think more systems, like as we were focused on our non-medical driver of health programs, what would be paramount for that? And there were a handful that we've focused on: bold goals, balanced accountability, portfolios of interventions, capturing community voice, and the fact that, of course, that we're data driven. So we'll touch on this a little bit more as we get into our conversation today. So our panel, we have an amazing panel. I'm thrilled to be able to introduce them. I will let each of them introduce themselves individually. They'll do a far better job than I can. But Shmanti, Susan, and Jen all come at this question of systemness from a very different type of organization and actually very different backgrounds. Each of them thinks about uses of data in very important ways, but slightly different ways. And each has a leadership position in their organization where they need to tell their impact narratives to diverse and different stakeholders. So those differences of their stories will come out as we dig into our panel today. And before I let them loose, I do want to give a couple guideposts as we go through our conversation around what to listen for. I touched on one. You'll hear a little bit of this difference in how each of them apply systemness to their approaches to impact measurement. They'll also hear some of this role of leadership in managing a little bit of that tension between goals that might be more at that individual level of the silo, but collective impact, which happens more at that level of system. And from a leadership standpoint, how one manages that intersection. And then what we want to do as well is begin to think how, as a consortium, perhaps we can move the needle on the systems-based approach. So those are a couple things to listen for. So with that, I'm going to stop sharing my screen, and I would ask Shmanti if you wouldn't mind beginning introducing yourself, the work you do at Michael and Susan Dell Foundation, and how you weave systemness into the work that you do. And then I will have Susan and Jen do the same things as part of our introductions and getting ourselves kicked off.
That sounds good. Thank you, Leslie, so much. And hello, everyone. Just great to be part of this conversation. It's one we live every day, and I'm always looking for answers on this one. So just a little bit about myself, Shmanti Basu. I've been with the Michael and Susan Dell Foundation in Austin now for 13 years. And I lead the measurement and evaluation efforts at the foundation. And what that means is, just like Leslie referenced, it's not just thinking about, are the investments we're making the right balance of investments that can create the change we want to see, but how are we connecting the dots as we're thinking about the group of investments we're making in terms of moving the needle forward for those people who experience these circumstances and challenges. So for us, the work is really centered around opportunity. And so when I think about systems, for me, it's a two-part situation, right? One is, how does the system now enable this individual to reach their full potential? And then what is the role us as funders can play in bringing that component of that system together for that individual, so that we are then facilitating the journey of that experience in the space that they exist in. So what that looks like for us, and just to give you a little bit of a context of our organization, we're a global foundation. We're in 3 countries, United States, India, and South Africa. And our sort of gamut of interventions sort of run the score of education, family economic stability. A lot of family stability is part of that work as well, jobs and livelihoods, as well as post-secondary success. So it's it's quite a broad sort of spectrum of, success measures that we are focused on. And as we think about that, we really think about there are so many things that can get in the way of each of those outcomes. So when you're thinking of a healthy person, and what does that mean when you're thinking about that person's ability to go and get trained and upskill, or when you're thinking about a child in a school, and what are all the different environmental factors that can get in the way of that child's learning ability. So that's the way we think about our grant making. And with that in mind, our health portfolio is very focused on trying to tackle health as a barrier. And that's very much in the central Texas space right now. And really think about three pillars of the health portfolio. One is around just the capital investments that we make. So those hospitals, those FQHCs, those clinics, making sure that those are institutions that give the highest level of quality for a patient who comes in the door. The second is the capacity piece. So as these institutions and these services are being generated, how are we bolstering the support and the technical assistance to make sure that our workforce in these hospitals, as well as these different clinics, have the best knowledge and tools to be delivering these services. And then the third bucket, and this is where Leslie has had the good fortune of trying to get in our brains and understand how to do this work, is this idea of comprehensive services and how do you connect clinical care to social care and everything in between, such that the patient experience is really not a unique one every time they walk into a new door. And for us, it's a little bit bigger than health as well. So it's not just an FQ working in the clinic and that space, it could be the workforce agency in that community as well, who's asking the same question, connecting you to those services, or the school district, who has a clinical social worker in the schools as well, also trying to sort of, wrap around for that family all of the services that they need. So that's kind of a very broad, brief introduction. But hopefully what you're getting out of that is it's a conversation that's top of mind for all of us. And when we think about impact, it really is that individual outcome changing, but what are the root causes along the way that have helped us sort of enable those individual outcomes to happen? I'm going to pause there and give the floor to Jen.
That's great. Sonja, thank you very, very much for that. Okay, either Jen or Susan, who would like to go next?
I can go next, Jen, unless you want to arm wrestle for that or something. So
no, that's just fine.
So good afternoon again. My name is Susan Hoff, and I'm the Chief Strategy and Impact Officer at United Way of Metropolitan Dallas, which our catchment area is 4 counties in North Texas. So Dallas being the largest, Collin, Rockwall, and Southern Denton counties. I've been with United Way Dallas for just about 12 years. My background is primarily in education, but particularly in youth and family services. And so I have been at very, very small startup organizations and big ones. And United Way is probably the one that has the broadest system level focus. So we talk about United Way as a social change organization, and we're focused on 3 key areas, very similar to the Gates Foundation, but education, income or financial stability, and health. And we have a strategic roadmap that we created with many, over 200 community partners from all kinds of sectors to focus on a 10-year roadmap to move toward goals in each of those 3 areas. We call that roadmap Aspire United 2030. And top level, like system level goals or community-wide goals in each area. In the education arena, for instance, our focus is to increase by 50% by 2030 the number of 3rd graders who are reading on grade level. In the income arena, it is to increase by 20% the number of young adults who are earning a livable wage. And in health, our focus is at the top level is to increase to almost universal the number of North Texans who have healthcare coverage. There are many things under each of those goals. You guys all know that, third grade reading does not start at 3rd grade or even 2nd grade. It starts well before you're born. And there's a lot of intersectionality between education, income, and health. The child's health affects their school outcomes affect work and employment, and health is underlying and focuses on everything. And so again, those are our focus areas. Everything we do, from the grants that we make, the investments in community partners, to projects and initiatives that we ourselves curate and help lead in the community, and advocacy and policy efforts, all align with our Aspire United 2030 goals. And I love the word systemness. That's such a great word. When we think about systems and systemness, which basically, and non-medical drivers of health, which basically, again, is pretty much everything within our Aspire United 2030 roadmap. We have created a system with our partners, PCCI and Leslie and her team, to look at cross-cutting indicators. So looking at communities, and just as Shimoni said, we're targeting big change at the systems level in education, income, and health, but what are those things that either facilitate someone moving forward at a community level toward those outcomes, or get in the way of them? And then by taking that and analyzing zip code and down to census tract level, what are the areas of vulnerability? What are the areas of strengths? Where are the things that where should we be focusing our resources? And even more granular, what resources ought we to be focusing in specific neighborhoods? It is a real switch from a traditional United Way model, which this United Way came from a traditional model. We were about to celebrate our 100th anniversary. And for about 80 years, we were pretty much what you would think of if you have familiarity with the United Way organization, which I would call our area of focus was what I would call sprinkling goodness. We had collected and received money from lots of corporations, which was wonderful. And we tended to take it and spread it broadly amongst a small set of community organizations, about 90. So it was sprinkling across our catchment area. It was a mile wide and about an inch thick is the process. And what you can imagine is when we were not really measuring toward key outcomes, then you couldn't really tell what difference we were making. Good things were happening, I will say that. That's the sprinkling of goodness model. But as we begin to hone and focus on how do we tell if the resources that we are investing and using for programs and advocating for are making a difference in the community, we had to figure out what were those differences that we wanted to make, what were those goals. And so this switch really moving toward long-term goals, measuring our progress, both at the organizational, so the community level, so the organizations and partners we work with, telling us what is their organizational progress, but then also laddering that up to the system level outcomes. How are we seeing if our theory of change is that by pushing the needle in very specific places in key neighborhoods, then we should see changes in the top level goals or the systemic goals. And so that's our model, and that is the work that we are about.
Great, Susan, thank you very, very much for that. Jen, would you please round us out?
Unmuting would be helpful. Sure, I'd be happy to. So my name is Jen Miff. I'm the president of the Dallas-Fort Worth Hospital Council Foundation. Say that 20 times fast and you'll get a prize. We are a 501c3, but we are part of a metropolitan hospital association that has been around in this market. We cover 16 counties, maybe 17 if you're counting uniquely, in the North Texas market. And that hospital association has been around for over 50 years. And we have a long history of the health systems in this market, even though they are quite competitive, cooperating and collaborating for the good of the community, quite unlike anything I have seen elsewhere in the country, to be quite honest. And so my background, I've only been with the foundation for about 4 years, just pre-COVID. And prior to that, I was in health IT in a care management market, serving primarily risk-bearing entities, ACOs and health plans. And prior to that, I was in consumer insights in the cell phone market. And so I have a long history of data, and we had no choice but to be systems thinkers. And I have a Baldrige background for anybody who happens to be familiar with that. And so I am hardcore through and through systems thinker. But in our particular organization, we sort of evolved that way naturally because of the nature of what we do. And what happened was, many of you are probably familiar with the Texas Healthcare Information Collection, known affectionately as THCIC. And about 20 years ago, that got started with Texas legislation. And somebody very smart and very forward thinking at the council, our parent Metropolitan Hospital Association, said, if we collect the information from the hospitals and help them clean it and submit it to the state, we would not only be helping the hospitals, we would have a data resource for the region. And so what do you know, that's what we started doing. And we've been collecting that data now. It is hospital discharge data, what we call pre-adjudicated claims. And it is valuable for many, 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 many things. And we've been doing it for so long that it has evolved over time into more of a system that brings together various types of information for deeper analysis and more use cases. And so we've added over time, for example, we now have Experian data, so you can look at the financial situation someone has. We have census tract information, so you can get to a block level and understand what's going on. And we have a separate system. When I think Leslie at one point asked what our wish list was, my wish list is to have that integrated at the case level in our full data set, but I can't have everything. So that is about 250 metrics. It's called Healthy North Texas. And that's about 250 metrics that are non-medical driver of health related. And they tend to be things like incident rates of chronic disease in the area, suicide rates, all of the sort of broad governmental data that is available, as well as things like food deserts and other information that supplements what we get from Experian and the census tract data. And so we have evolved very much into a system that is used for a variety of use cases within the hospitals, within academic partners, and with community-based organizations, especially when they want to assess outcomes from grants. And so that tends to be, I think, where we really shine, because the other big advantage that we have is that over time, as we've evolved into a data system, we have added a very sophisticated matching algorithm that allows us and our partners to match up to other data sets. And so we can do things like, we had a study that was a community health paramedic program that on discharge, it was driven along the discharge workflow. And it took people who were at risk of a readmission and put them into the program. A paramedic went to their home, made sure they had filled their prescriptions, made sure they had the right medication, made sure they knew how to take it, made sure they didn't have fall risks, made sure they had food, made sure they had neighbor support, et cetera, and so forth. And readmissions improved or declined, I guess I should say, 30 points. Actually, a little bit more than that, in the mid 30s. And so it was so successful that several of the hospitals started funding it themselves just to keep it going. And we have another study going on right now with MHMR Tarrant County that is looking at the success of their mobile it's not really telehealth, it's a mobile unit that goes out and responds to behavioral health issues. And they are using our data to look at the outcomes because, again, we have inpatient and outpatient, the entire encounter. And so you can see, because of that matching, you can see what happens to someone over time in a particular area. You can look at emergency department utilization and readmissions. We have about 97% market coverage in the region. So we're very lucky because we've sort of just evolved this way. And I would love to take credit for it. But again, I've only been here 4 years and most of it happened long before I was around. So that's my story.
Great.
And really, I mean, I would say in terms of our role in one of the things you asked us to talk about was our role. And really, we see ourselves as the convener in the community that brings everybody together. And we don't just do that around data. We really, let's be honest, one of the big ways the hospitals use our data is for market analysis. And so it's a business intelligence tool that they can use to look at a variety of things. But in community health and workforce and patient safety and quality, those are the areas where we come together. And where we really succeed particularly well is when the hospitals share best practices with one another. So, for example, C. diff, there was a big issue in the region maybe 6 years ago with C. diff. And we used the data to identify that this was a priority. Then we used the data to identify the top performers in the region. They shared their best practices, and as a region, we improved 7 points in a year, which is pretty remarkable. And so these are the types of things I think we are able to do in our region that you often can't do elsewhere, that I think is a real advantage.
Jen, thank you so much for that. So if you're listening keenly, each of our panelists described Systemness in a very complementary but slightly different way. Shamanti started with the system for the person, being how we put all of those resources around that person to make their system the most effective system possible. Susan spoke to systems as those ecosystem partners around collective impact, around deciding where to prioritize on and double down on programming such that we can move the needle the furthest in those areas where the needs are the greatest. And that requires a system of different types of organizations, because in those most problematic areas, it's food and transit and safety and income and education. It cannot be one siloed organization per se, because the needs are multifactorial. And then Jen talked about systemness in terms of how we think about bringing a lot of data resource together, such that particularly in healthcare, well, you didn't go for utilization here, but you went over there. So we didn't really solve the problem. We just moved the problem. And so the ability to have that level of longitudinal information, the willingness in those right situations to share that information. And then the other thing that you said that came across loud and clear to me is being a partner for those who want to do research, who might not be as data savvy, to have perhaps you be the organization to help guide what that measurement story would look like based on the type of information that you have. So we said systemness, we promised you systemness, and we gave you 3 very different facets into that definition, all appropriate, but all just slightly different. I'm curious, for Shamanti, Susan, or Jen, have you heard systemness in the context of non-medical drivers of health framed any other way than the 3 ways that we just touched on? We've got at the person level, we've got at the kind of organization doubling down on the funding level, and we've got on the data and the kind of that longitudinal use of information. I actually can't think of one, but I just thought I would toss it out there. It wasn't meant to be a stumper, like that trick question in the middle of the panel. I was just curious if anything else came to mind. Okay, so
I think the only thing I would add to the data point is that interoperability of systems. So when we think about just the idea of a data that is transferring from one environment to the other, I think that is a given, but I think that's oftentimes what keeps us from really systemness from happening. So I just add that nuance.
Okay, great, thank you for that. So Jen, I'm going to start with you, and we're going to work the backwards. I see the four on my screen. I'm going to go the way I see you all on my screen. And when you and I had our prep call, one of the things we talked about was, if you get your head too much in the world of the big S systems, like the perfection, you kind of just become the ostrich and put your head in the ground, because it seems a little too overwhelming. But yet, if we stay at the silo level, we're never going to solve the problem, because we can't solve this in silos. So you and I talked briefly about that middle ground of kind of maybe that little S system. So in the context of your world, when you think about that middle ground, It's making the best use of what you have. What does that look like? And how would you kind of describe the utility of that to all the folks on the call today?
Yeah, so great question. And I think a really important point in trying to manage change, because sometimes we just get so wrapped around the axle on the integrated, interoperable system. And again, I came from health IT, and in health IT, that was like the holy grail, right? Where you're going to have the CCDA and the, all these different feeds. And we were owned by a very big health plan, and they were the last ones to go SaaS, to move to the cloud. But by the time they were done, they had 15 different data feeds. It was the most, everything was HL7. It was very, very sophisticated. And, the truth is they had trouble actioning a lot of those things. And so sometimes you can try so hard on the IT and get and fight to have all this perfect data. And it's not really, if it's not tied into the workflow, if there's no way to get that back, in my case, it was to the care manager at the point of care who was coaching the patient who just had a cabbage procedure to use the scale and weigh themselves every day, right? And so it has to be integrated to the workflow. And sometimes we worry, every health IT conference I go to, even now, we're still talking about, oh, we got to tie it all together and we have to have everything in one system and everything has to be integrated. And no, it really doesn't. And I'll tell you, when I got over to the foundation and realized how sophisticated our matching algorithm was and how much we could do with that, who cares if the systems are integrated? Now, there are times where I would like to have an HIE, but I'll give you a perfect example. So one of the EMT organizations in the region, we had tried to do some stuff with mental health, and we made it all about having an automated referral to this particular organization. And I won't say anything about the specifics, but everything was about this automated referral, and we had to get it to in the system. But guess what? There was a 30-day backlog on the other end to provide the services. So it didn't matter that we had an automated referral. And in fact, it would have been better if we could have sent somebody in the field to intervene and keep them out of the ED in the first place, right? And so sometimes we make things data problems when they're actually not data problems. And so I said to myself, well, gee, what could we do with our data that could be useful? And there's an EMT organization that's part of an HIE. And I said, well, could we come up with a percentile of prior ED utilization and prior behavioral health diagnosis? Just a rating, like from 1 to 10. So just a kind of a percentile thing. So not HIPAA, getting around HIPAA. Mm-hmm. And I said to them, if we could deliver this to you through the HIE in real time, would that help you? And he said, well, let's talk about this. And he said, a third of the time, I don't even know who somebody is, because they're so challenged that they don't know who they are. So maybe there's, that serious of a mental or behavioral health condition. And so a third of the time, I can't even do a lookup to see what and then where else am I supposed to take them besides the ED? What other resources do you know that we have? Well, we don't have other resources. And so I was going to do all this sophisticated stuff to fix the data, but the workflow wasn't tied in and I wasn't going to be able to action it. So what difference does it make? So sometimes we can do a lot with what we have, and we have to think through the question we have, the problem we're trying to solve, and can we do it good enough with the data that we have, whether it's matching it offline or doing it in some other workflow where it doesn't have to be this real-time HIE notification. And so I think that's really, sometimes that really gets in our way because we're overthinking and overcomplicating.
Yep. So Jen, I'm going to come back to a couple of points that you made. Susan, I'm going to come to you next. That middle of the road systemness, not a silo, not a Pollyanna pie in the sky system. What's your kind of middle of the road system?
So excellent question. So, let me kind of back up and tell a little bit of story. So I talked about, moving from a sprinkling goodness into to a goal focused, and we did that first iteration of 10-year goals in 2010. So we had but we started by just kind of shifting our whole system and say, these are 3 big goals we're going toward. They were in education, income, and health, slightly different than the ones we have now. But then we didn't really think through, okay, so how does the work that we do, whether it's investments, as I said, or initiatives and projects, how's it ladder up to that? So we were almost like measuring 2 different things, like these big community level goals, and then stuff we did, for lack of a better word, and moving from that to kind of focus areas to the middle ground, Leslie, is we worked with our at that point our grantees, so we have about 150 of those, and brought them around the table. We'd already we were investing in people that were in organizations that were aligned with our education, income, and health focus areas, that said, how do you measure your work? Because previously they just sent in, if we had 150 grantees, I probably had 150 different ways they were measuring things. So we worked together over a period of time with our partners or community partners to come up with, we originally wanted them to be common measures, and everybody said, we're going to measure exactly the same thing. That did not quite come out, but they are aligned measures. And so, and there's a set of about 120 aligned measures, which then when organizations report to us their progress over the year, or when they apply to us for funding, they tell us which of these other areas are they going to be measuring and reporting to us, or anything else they want. So then, taking it down even further, though, because 130 is a whole lot, and our board said they don't want to listen to 130 different things. Thank you very much. And so we created indices for education, income, and health of about 10 of those 130 measures in each area, really kind of what I would call the ones that research tells us are most indicative that these are probably the biggest drivers toward our goals in education, income, and health. And so we collect all the information that our partners send to us, but then we hone in on those key indicators, and that creates an organizational scorecard that we then can make assumptions that if we're doing well in these areas, then we should be seeing change at the systems level in the big area goals in education, income, and health. So it is nowhere near as scientific as what Jenna's describing, but it is for a community organization with multiple partners. I think it is the kind of work
the middle of the road. Yep.
For us. Yeah.
Yep. Very good. And I have a couple of things I'm going to circle back that you said that really struck me. But before I do that, Shamanti, your middle of the road system definition.
Yeah, I just love what both of you are saying. And I think the one thing I'd just say as a funder, you just have to be responsible, right? Because every time you get curious, it creates a data burden on your grantees. So I think, managing that discipline of saying, have you done the job of really articulating your goal and the change that you expect to see, and for whom? Is it for a group of individuals? Is it for a place? Or is it that you've created tipping points? So for us, from a sort of measurement strategy standpoint, I think it's a 3-pronged approach. We use proxies a lot because we get data from organizations that we're funding, and we would rather have them do the work than try to collect the data to tell us that they're doing the work. So, that balance of, are there key metrics, just like Susan, you're saying, that align with what we expect to see? And then how does that serve as a proxy for organization or service quality? And then our theory of change is, how do you create tipping points in the system so that if you have a critical mass of high quality organization, the system is at a level at which you've created access for those individuals? So that's the other thing we think about. So we think about organization quality and is there enough of a tipping point in the system? Then we think about what is the proportion of access we've created for those individuals we care about. And then where we go deep is very selectively and very systematically to say, is anyone better off? And what that means is we don't try to get that across the board for all of our grantees, but we might actually sort of think about it from okay, we've done this for 5 years, let's go and try to understand what actually has changed, or let's do a focus group, or we feel good about the strategy, let's actually validate that with those stakeholders to whom these services are designed for. So it's a balancing act, and I think at any given time, what we're really balancing is, do we have a focus? What is this change that we expect to see? Is it at the individual level? Is it at the organization level? Or is it in a system, which is a place in some cases? What's a good proxy, and then what do we directly need to measure from an impact standpoint? So let's ask the beneficiaries themselves whether they see that change that we think is happening on the ground. So it's always that balancing act of trying to bring it back to our goals and then say, does that then represent a healthy system of change that we want to be able to see in our investment portfolio?
So I jotted down a couple things that I think encapsulate this middle of the road world that I think for everyone on this call is reasonable. I think if we're talking about where we want to be, where is a consortium we should strive to be, I think acceleration towards the middle would be great. I think if we look at ourselves as a state, we are probably a little further away from the middle than we'd like to be, and so getting to the middle, I think, would be viewed as a as a terrific win. A couple things that I heard. One, a lot of the times challenges that we're trying to maybe lay on the shoulders of being a data problem really aren't a data problem. There might be a problem with the data, but it isn't actually the root of the challenge. And so beginning to look at what we're trying to accomplish with a very clear query statement, and then really understanding what type of data you need versus looking at the data that you have and saying, what type of questions can we address? So Jen, that was a little bit of interpretation of mine from your comment that not all problems that we see are data problems. Well, often they may be workflow or other type of challenges. So level of systems thinking is to get a mindset out of maybe some of the traditional ways, we're looking at problems, challenges. One of my favorite quotes is the difference between performance improvement and innovation. Performance improvement, you study the line, you say, why is the line long? How can I make the line faster? How can I make the line more enjoyable for people in the line? If you're viewing the question from an innovation hat, you'd ask the question, why is there a line in the first place? So I think there's a little bit of that dichotomy here. When we think of that middle of the road systems, we should be able to look at some of our challenges with more of a holistic lens to be able to understand some of their root causes before we do that solutioning. Susan, what I heard you say is that as we think about this middle of the road systems, we're going to have a mix of different organizations, a mix of people who fund different things, and we can go from everyone telling us anything independently from a core set of measures that's so fixed that we're doing a lot of the square peg into the round holes. So we haven't made it so rigid, but we've gone from the completely scattershot. And so we put a ring fence around that has a little bit of that structured flexibility that allows for a way to understand impact in a little bit more of that middle of the road way. Shimanti, what I heard you say in that middle of the road systemness is that if we want to create middle of the road systemness still requires creating tipping points. And for creating tipping points, you need some critical mass. So for you, systemness, it's maybe a little bit different from how Susan thinks of it and how Jen thinks of it. But if there are initiatives that are important for the work that you're doing, how do you make sure that the amount of program that's out there, the amount of research, the coverage is there such that you can create enough of that and a tipping point to affect some of that positive change? Did I capture that? Or any other ands or addendums to that in terms of each of your views on middle of the road systemness?
The only other note I had that I would add to that idea is you had asked us in the pre-questions about our barriers. And one of the barriers I wrote down is finding a common cause as a region. And to be fair, some of the reason, again, we've got this long history and we've had all this time to evolve. And so I sometimes feel like I sort of get that as a gimme, right? But when we struggle still is when we're trying to come around a common goal for the region. And we find in community health, it's harder to identify that common goal than in something like quality. So a lot of the examples, the community health paramedic program that I gave you the example of was about readmissions, which is a common goal for every health system, right? And other times when we're doing things like I have a pre-diabetes program with the state, that one's a lot trickier. And so sometimes it's not that we don't all want to help folks who are pre-diabetic but there's only so many programs. We have program constraints, we have workflow challenges. And the data on that, I mean, we used our data to identify the clinics where there's an over-indexing of diabetic rates of diabetes in the hospital. So really serious cases, over-indexed 2.5 times at one of the clinics we have engaged. But my metric is really just participation and how many people I'm referring. And I think the grant organization was very smart to keep it that way so that people weren't scared away from participating. And so I think to Samanti's point before, you have to be careful about the burden on the grantees in the community health space in particular, because they're not used to measuring. And sometimes it's really tricky. And so how do we kind of build it gradually and slowly to kind of develop the base and the skill set and sort of that starting point?
No, I agree with that completely. And, one of the things that we work on and continue to try to work on, I talked about the aligned measures coming from the actual program or service providers, but to come up with a set of aligned measures or common measures that funders have, because just to your point, Jen, and we as many people have multiple funders that I have slightly different things I have to report to each one. They're not that much different, but they are different. And when you take that and you put it at a community level to a small organization, and they maybe have 10 or 15 funders who are asking for a slightly different report, it becomes really, really challenging for an organization. It also makes it difficult as, at the funding level to even make sense of what we are asking. So an aspirational goal is how do we get investors and funders to be looking at or be asking for the same measures, or at least a set of the same measures.
Yep. Very good.
Let me jump in here.
Yep, please do. That's what I was just going to say.
Y'all are amazing. I mean, I love being a fly on the wall with people who are like really good at what they do, where I feel like, I've got it. Oh, I just missed there. And so 2 things, because we're really running out of time. One, this consortium is as good as we make it, and Jackie is going to drop into the chat a survey. So please take this survey, because that helps us know what we did right, what we did wrong, what you want more of. Also, check out our program index. And before people go, who's on there in the audience that has a comment or question? I didn't get anything in the chat, but if somebody just wants to shout something out, and if not, I'm going to go back and let you ladies continue this really amazing conversation.
Well, Elena, thank you for that. I will watch the chat. Jessica and Jackie have been helpful on that front. We have a few minutes left, so I'm going to ask each of you to provide one. So if we say that everyone on this call is still in their forming and storming level on their path towards systemness, and you have no idea exactly how each individual is defining it, one either word of advice or gem of wisdom that you would pass along as your parting shot. And Semanti, I will start with you.
Yeah, well, that's a heavy one. I would say start with the person. I mean, talk to the people that this system has to work for, because they are really good about telling you exactly where the redundancies are. So listen, and then formulate. And I think the second thing, if I could squeeze that one in, is be aware that not everyone in that system is at the same level of capacity and readiness. So when we are thinking as funders about how to fund systems, that has to be an augmentation for this to work. So to try to connect the dots without the supports to connect the dots is a little irresponsible from a funding standpoint. So it's something just to be aware of. So those are my two.
Very good. Susan.
Very similar to what you said, Shamandi. I mean, listen to those that are most proximate to the issues, whether those are the organizations that are providing the service or the people that are recipients of the service. Listen and incorporate and try to simplify as much as possible. You know, it is real easy to take something that's not even all that hard and make it so complicated that no one can understand it. My stance is always to try to do the opposite.
Yep, I love that. Jen.
I'm going to go back to something you said earlier, Leslie, in your intro slide, which was start with the outcome, right? So back in for-profit, you know, you'd get crazy people from the business coming to you all the time going, I want to do this. And I'm like, wait, whoa, let's take a step back. What are you trying to get to? What problem are you trying to solve? What question are you trying to answer? And whenever we were doing a big change management effort, that's what we always took people back to. What decision has to be made at this point, and what data do you need to support that decision? And if you do that with your stakeholders, make it collaborative, then defining a simple measure to start to get at it is not as hard as you think it will be. And sometimes you have to focus on what you can measure.
Yep.
Instead of worrying so much about all the stuff you would like to measure.
Yep.
I mean, I would love clinic data and be able to look at rising risk, and guess what? I can't do that. So I got to get over it and move on, right? And so if I keep dwelling on the fact that I don't have clinic data, well, you know, I'm gonna not be meeting my stakeholders' needs. And so I think that's really key.
Very good. Thank you all so much. We have 2 minutes left. So on behalf of the consortium, on the behalf of the panelists, thank you for sharing your stories with each other. I think you have all got to know each other a little bit more as individuals, which is great. For everyone on the line, you're looking at resources here. We're all in this together. So as you think of things as follow-up, certainly don't be shy in reaching out. And for Elena, Jessica, Jackie on the consortium team, and everyone who helped on the back end, thank you very much for putting this together. I think we can officially call this one a wrap.
Thanks very much, everybody. Please take this really short survey so we can keep giving you content you want. Thanks, Leslie. Thanks, Jen. Thanks, Susan. Thanks, Shamandi.
Okay, bye, guys.
Bye.
Thanks for having us.
Thanks. Bye-bye.
Bye.